Welcome to this educational video on herpes zoster or shingles. This video is presented by Professor Robert Boy from the Immunisation Coalition. After the presentation is a recorded panel discussion from the live webinar. If you have questions following this video, feel free to contact the Immunisation Coalition via the details on the screen now. Let's get started. Over to you, Professor Boy.
Well, it's a pleasure to be with you all this evening, and thanks for that lovely introduction. My name is, as you know, Professor Robert Boy, and we're going to be talking about and discussing herpes zoster, otherwise known as shingles. Herpes zoster is the reactivation of the varicella zoster virus in someone who has previously had chickenpox. Now, almost everyone is seropositive for chickenpox by the age of 30. So there is a risk in almost everyone of getting zoster in later life. It occurs mainly in people over 50 years of age, and usually it appears as a painful rash with small blisters just on one side of the body, the face or the trunk or the neck. Globally, herpes zoster is becoming more common as the population ages, as people live longer lives. So, after you've had chickenpox as a child, the zoster virus can remain dormant, quietly sitting in your nervous system, in your dorsal root ganglion or the trigeminal ganglia in the brain. The virus can then become reactivated later in life within a year or two, or usually within many decades, and most commonly in older adults over 50, and also in those who are immunocompromised. In my own family, I had zoster as a medical student many years ago, whereas my sister had it when she had immunosuppression, and my mother had it from immunosenescence, from being old. So the reactivation of the varicella virus then goes down into the skin via the nervous system, and then leads to the blisters and pain. And here you can see a cartoon illustration of how that happens. So a question for you. Can shingles itself be transmitted from one person to another? The disease shingles, can that be transmitted from one to another? A, no, shingles is not contagious, and the varicella zoster virus is not contagious. Or B, yes, it can be transmitted by contact with eating utensils or infected individuals. C, no, shingles is not contagious, but the varicella zoster virus can be passed on to cause chickenpox in a person that has never had chickenpox. Or D, yes, shingles is a sexually transmitted disease. Well, that's a bit silly. What's the answer, please? Well, as just about everyone would know, the answer is C. No, shingles is not contagious itself, but the virus can be passed on and cause chickenpox in a person who's never had chickenpox. That's an easy one. Let's move along. So shingles can't be passed on from one person to another, but a person with shingles can pass the virus to someone who's never had chickenpox. Persons exposed to the virus can develop chickenpox, but not shingles. Straightforward. It's spread by direct contact with the fluid inside the vesicles, the blisters. And after a few days, the blisters scab over and become non-infectious. So how do you prevent transmission? That's the important point. Cover any non-crusted shingle lesion, a vesicle, a blister, with a non-adherent padded dressing. Bathe regularly with saline to remove the exudate and crusts, and avoid susceptible contacts, people who are likely to get the infection, especially people like pregnant women or the immunocompromised who are on treatment for cancer, or they've got a blood cancer or a bone marrow transplant. So the early phase, the early symptoms, in most cases, there's a prodromal phase that lasts 2 to 3 days before the rash actually develops. People think, oh, there's something wrong, but they don't know what. So the early symptoms may be just itching or pain, or numbness, or all three in the affected area, such as one side of the chest. And it can be accompanied by headache due to a mild viral meningitis, or sensitivity to bright light and malaise. So this is what the rash can look like when it's developed and it's already starting to crust, as you can see. So a blistery rash that follows with pain, which may be increased in nature. And as the band of blisters erupt, they become larger in size and they can move around, often the thoracic, the chest, or even the lumbar region, or the neck, or even the face when it could be more serious. Generally, this rash is self-limiting and lasts 10 to 15 days, but it can become more serious because, for example, secondary infection with bacteria may occur, especially if it's scratched or itched. So what are the important complications? Well, probably the most important is PHN, post-herpetic neuralgia, where the pain lasts at least 3 months. The pain and the nerve damage can begin before the rash is visible, as I've already said, and it can become really quite debilitating. And the pain is especially at the site of the rash. And as I said, if it lasts 3 months or more, it's called post-herpetic neuralgia, long-term pain. The incidence and the duration is more common the older you are. So it really starts to rise in your 50s, even more in your 60s and 70s. About a third of people with shingles, about a third of people over the age of 80 years will get shingles. If you make it to 85, it's nearly 85. It's nearly 50%. If you make it to 100, almost 100% of people will get shingles. So the post-herpetic neuralgia, which we're most concerned about, the ongoing and sometimes excruciating pain, can last for an average of more than 3 years. So that's not nice. And some people find the pain so debilitating they get depressed and occasionally even suicidal. So if you get it on your face, you've got more likelihood of a complication. If you get it in the upper part of the face around the eye, you can get ophthalmic zoster, which can occur in probably around 10%, sometimes 15%. And the complications can include scarring and even sometimes loss of vision. Stroke is also a risk, as is heart attack. Shingles may also increase. Shingles increases the risk of stroke, especially in the 6 months after you've had it. And in the 4 weeks after shingles, there's an increased risk, which is even higher. There's for stroke, that's for stroke. For heart attack, the increased risk is nearly twofold, especially in the first week after the diagnosis. So the complications of a vascular nature are really quite worrying, and they can occur even in the first week or up to 6 months later with respect to stroke. Rarely you can get pneumonia, you can get hearing damage, and rare cases lead to encephalitis and even death. So who's at risk? Well, the photo suggests it already, older people. We think that about 30% of people who live into the older age, into retirement age, will get it, but we really start worrying about it from the age of 50. And that's when products for its prevention are licensed from as well, I hasten to add. So 95% of Australians aged over 30 have already been infected with chickenpox, the varicella zoster virus. And about half of people, as I said already, who get to 85 will develop shingles. It's much more common in immunocompromised individuals, and worryingly, it can be more severe and it can be recurrent. So if you're immunocompromised, and sometimes you don't realize it, you may have a blood cancer like chronic lymphatic leukemia and not even realize that you've got that, and then you develop shingles on top of it because of the immunosuppression. So in Australia, we suspect that there's about 120 to 150,000 new cases every year, and mostly in older adults. The burden goes up, as you can see, and the national notifications, interestingly, have shown recent increases. Partly that's due to better reporting, and there are possibly other reasons as well, secular trends that we're not aware of, but it is a disease worth bothering with. So the next question, can you develop shingles more than once? Well, have you been listening? Answer A, no. Answer B, yes, but it is uncommon, with one study estimating a recurrence rate of 6%. Go back forward, please. We've gone back in the slides. Thank you. C, yes, but recurrence is more likely in men and anyone aged less than 50 at the index episode. That sounds a bit strange. And D, yes, and recurrence is more common in immunocompetent people. Well, that's an easy one to answer too, isn't it? What's the answer? So, can you develop shingles more than once? Yes, but it is uncommon. One study estimated a recurrence rate of 6.2% at 8 years. For myself, I think my mother probably had it 3 times, so occasionally you can have it even a 3rd time. So there's a couple of vaccines available. One called Zostavax, which has been available in Australia now for about 5 years. It's a live but attenuated viral vaccine, and it's available on the NIP as well as privately. I've had that vaccine myself. And more recently, there's a new vaccine called Shingrix, which is inactivated, so it's not live. It's not available on the NIP, but it is available by private prescription, up to $300 per dose, and you need 2 doses. What it contains is a protein from the varicella zoster virus. The protein is called glycoprotein E, and it's adjuvanted to AS01B, which is an adjuvant system from GSK, which means that the vaccine is much more immunogenic as a consequence of the adjuvanting. But you still need, because it's a dead vaccine, you still need 2 doses. And because it's adjuvanted, you may get a few more side effects, but let's talk about that in a moment. So who should be vaccinated? Well, all adults 60 years of age and above who've not received a dose should get one. Household contacts of them who are more than 50 years of age, particularly of a person who is or is expected to become immunocompromised. For example, they're about to go on chemotherapy or radiotherapy. So you can give a single dose of Zostavax, and that's available in the National Immunisation Program for adults from the age of 70 to 79. And you can have a single catch-up dose of Zostavax funded for the 71 to 79-year-olds. Now, that was extended until the end of 2021, but it's just had a 2-year extension right up till 2023, October 2023. So that's hot off the press news. So who especially should be vaccinated? I've mentioned my own family history, immunosuppression and immunosenescence. So reasons for your immune system to weaken by disease or by age. So people with chronic conditions like having no spleen, diabetes, rheumatoid arthritis, treated with high-dose steroids, people with renal disease, heart disease, skin disease like psoriasis, but don't give Zostavax, the live one, if anyone is thought to be or could be immunocompromised at the severe level. So it's a very careful thing to check when you're about to give someone Zostavax. Is there any chance they could be severely immunocompromised? And also, we also vaccinate people at high risk of cardiovascular disease. So who should not be? Well, pregnant women is one. Previous anaphylaxis to the vaccine, people who are immunocompromised through a primary immunodeficiency or a severe acquired immunodeficiency. So that's things like leukemia, lymphoma, other bone marrow problems like multiple myeloma. And then there's problems of the immune system that's acquired like HIV/AIDS and cellular immune deficiencies. Severe, high-level immunosuppression with steroids, and the dose to look out for is at least 20 milligrams of prednisolone per day or the equivalent. Zostavax is not contraindicated for people who are receiving topical or low-dose inhaled corticosteroids. So it's only for those who have a pretty high dose. Okay, time for another question. So how is Zostavax administered? A, as a single dose subcutaneously. B, 2 injections intramuscularly 2 months apart. C, 2 injections subcutaneously 2 months apart. Or D, a single dose intramuscular reconstituted immediately after removal from the fridge, administer immediately after reconstitution. Which of those? I'm going to take a moment for you to think about that and write your answer. So it's given as a single dose subcutaneously, you reconstitute immediately after removal from the fridge, etc. One more question. How is Shingrix administered? Single dose, subcutaneous, A. B, 2 injections IM 2 to 6 months apart. C, 2 injections subcutaneous 2 to 6 months apart. D, single dose IM. So which is it? I'll let you ponder for a moment. Which is it? Pretty easy, I think. Yes, it's B. It's given as 2 injections intramuscular 2 to 6 months apart. The reason you have the second dose is you get stronger and longer immunity. Okay, before vaccinating with a Zoster vaccine, you need to do some simple things. And the practice nurse may be able to help with this. Get a medical history checked, especially for immunocompromise. We've seen a handful of fatal outcomes with Zostavax, and in both Australia and the UK, and they've been in people with leukemia, lymphoma, immunocompromised. So if someone is immunocompromised, you don't give Zostavax unless you've carefully considered it and looked at their level of immunosuppression. And if it's likely to be severe, then you don't give Zostavax. If there's any uncertainty about the level of immunocompromise, you don't give the vaccine. You get expert advice from an immunologist or an infectious disease specialist, and you can look it up on the National Immunisation Program for the contraindications as well, or at the National Centre of Immunisation Research and Surveillance. They've got an excellent website which helps you through making those kind of choices and decisions. National Centre Immunisation Research Surveillance, NCIRS. Okay, so this sets out the details of the immunosuppressive therapy that can and cannot be given. So therapy for less than 14 days, you can read yourself that high dose steroids can be a problem. So if it's less than 14 days, you can wait for at least a month before treatment starts. If the therapy with high dose steroids is for more than 14 days, you've got to wait at least a month, or at least 1 month after treatment has stopped. And you can read on the slide there the other indications. Generally, if you've got anything that may be impairing your immune system, like DMARDs, azathioprine, mercaptopurine, and so on, the slide sets out the doses, and you can look those up more easily. You and I will both go to sleep if I read this whole slide. So immunosuppressive therapy that affects T cell, such as T cell inhibitors like tacrolimus, cyclosporin, etc. Again, you need to wait at least a month before treatment starts, or at least 3 months after treatment stops. When I say wait, I mean you give the therapy and then wait a month before giving the T cell inhibitor. And the other ones, again, I'm going to pause for a moment, just for about 10 seconds so you can read the rest. I'm going to run out of energy if I read every slide. So again, this needs to be looked up on places like the National Centre Immunisation Research Surveillance website if you can't remember all of this easily, and I'm certainly not going to bore you with reading it all. So Shingrix is a different kettle of fish because it's a dead vaccine, because it doesn't pose a risk to the immunocompromised. So it overcomes the contraindication in immunocompromised people. So the effectiveness of Zostavax is really quite good, about 67% against the main worrying complication of post-herpetic neuralgia. That's a 2/3 reduction. So that's good. It's not perfect, it's not great, but it's good. So that means that a lot less people are getting post-herpetic neuralgia given that they've been vaccinated. The shingles prevention study, SPS, was done in about 40,000 adults over 60 years of age. And the prevention of actual zoster was by about 50%, a halving. It was the neuralgia that was more effectively prevented by about 2/3. It also found that the burden of illness associated with herpes zoster was reduced by about 60%. So that was really quite encouraging. It's a good vaccine. And then that study, the shingles prevention study, has been followed up with a retrospective cohort study, which has shown similar results and certainly benefit for people in their 60s, 70s, and even in their 80s. So overall, the effectiveness of Zostavax is good, around 50%, as I've said already. And people with chronic diseases, whether it's of the heart, the liver, the lungs, they too benefit. So despite having a chronic medical problem like kidney disease or diabetes, you get good prevention with the vaccine. Now I want to talk about the new vaccine, Shingrix, for which there have also been large phase 3 studies, randomized controlled studies, called Zoe 50 for 50 and above and Zoe 70 for 70 and above. And the results are even more impressive. 97% if you're over 50, very impressive. 90% over 70. So that is just great. And if you pooled the results from the two studies, again, it was just over 90% protection in the age group aged from 70 and above. So very high level of protection. And somewhat better than Zostavax. What about the safety? It's been shown in the large studies with thousands of people to be both safe and well tolerated. People who got the first dose almost always got the second dose, so they tolerated the vaccine side effects to the extent that they were very happy to have their second dose almost always. You can get some of the usual side effects that you get from vaccines like headache and fatigue, pain at the injection site, and it usually settles down over 2 to 3 days, like many other vaccines. I would hasten to add that the Shingrix, however, has a high likelihood of local side effects and sometimes of systemic as well, but they do settle within 2 to 3 days. What about Zostavax? Is there any risk of transmission of the chickenpox virus in people who've been vaccinated? Well, it's not been reported in the trials, but post-marketing experience shows that transmission in people with a rash can rarely occur. As you might expect, if you've got vesicles, there's virus causing that, and therefore, if that rash is exposed to someone who's susceptible to chickenpox, they can catch it. If there's no rash, that's much more unlikely to transmit. Although it's been reported, it's not been confirmed. So what can you do by way of co-administration to make things more efficient and keep our patients happy and protect them more quickly? Well, can Zostavax be given on the same day as another vaccine? And it can. All live and inactivated vaccines can be given on the same day as a live Zoster vaccine. Separate injection sites, separate syringes, of course, so co-administration into 2 different arms, for example. If the live Zoster vaccine is not given on the same day, you need to separate by 4 weeks. The immune system just copes much better and responds more effectively if there's a 4-week gap as a minimum. What about Shingrix? No serious safety concerns, and that's why it's licensed and recommended. But as I said already, 80%, a high proportion, can get an injection site reaction. And also, there's quite a high rate of systemic reactions like muscle ache, fatigue, and headache in about 2/3 of recipients of the vaccine, compared with 30% of placebo. So it is more likely to cause local and systemic side effects, but as I've said, they go away quickly. So, optimizing Zoster vaccine uptake, there's a lot of things to consider. We've gone over them already. I'll give you a moment to read the slide. What's important is that if you've got a practical and synergistic approach using your usual practice recall and other methods, and you also take advantage of opportunistic vaccination, you can get a much greater proportion of the people vaccinated than are already done so. The last 5 years has seen a lot of people vaccinated, but not enough. It has seen an impact, however, on the incidence of Zoster in the community, and the prescription of anti-Zoster medications has reduced. So we know there's been an impact, and we suspect with a vaccine that's more effective, we could have an even greater impact. But as I've said, the new vaccine is only available on the private market at the present time. Now for the treatment of herpes zoster. Antiviral treatment with famciclovir or valacyclovir or acyclovir is useful, but in the immunocompetent, it's best given within 72 hours of the onset of rash, but at any stage for immunocompromised patients who get it more severely. And there is evidence that famciclovir and valacyclovir are more effective than acyclovir in reducing acute pain. However, in pregnancy, there's more evidence to support the use of acyclovir. Management of pain is really important. We start with paracetamol, as you always do, but if there's severe pain, you can quickly move up to steroids, and alternatives when the pain goes on and weeks and months. Amitriptyline is a marvelous old-fashioned drug that's good for both pain, nerve pain, and also has an antidepressant effect and helps people sleep at night as well. And oxycodone is used sparingly and in the short term only if you've got severe pain. So to conclude, herpes zoster seems to be increasing as the population ages, and the incidence and the number of cases have been going up in Australia. Preventing herpes zoster, shingles, with vaccination is the best way to prevent post-herpetic neuralgia and other complications such as stroke and myocardial infarction. Optimizing the vaccination uptake can be best done by a cooperative, synergistic approach using recall as well as opportunistic vaccination, as I said earlier. And before vaccinating with a live Zoster virus vaccine, remember to get a careful medical history and check for even symptoms right now of immunosuppression that may worry you. If you're concerned about moderate to severe immunosuppression, check and pause and consider not vaccinating if there's any concern. Early management with antivirals and analgesia can reduce the pain of herpes zoster, but actual post-herpetic neuralgia can't be prevented by medical treatments. It's only preventable by vaccination, and that's really important to remember. Been a pleasure being with you. We've got some question and answer time now, so I look forward to that.
Thank you very much, Robert. Thank you for a very informative presentation on a contemporary topic of great interest to the Australian community. Thank you. Robert, we have several questions from the participants, and perhaps we could use those to have some discussion around the topic. One of the first questions, which I think probably needs to be answered, relates to money. And I've had a question which picks up on your comment about Shingrix costing $300. And the question is, does the $300 cover both doses?
Yeah, well, good question. And you may have noticed I've changed my shirt. Good to be with you. we did a pre-record and now I'm live. Look, it's as my understanding, and I'm not the expert, to be honest. I'm a clinician. I'm an infectious disease and vaccine expert. I'm not a economic expert, but as I understand it, that's per dose, not for 2 doses.
And I can confirm that, Robert, because I've had patients who've come along and told me that they spent $300 per dose.
Andrew, you need to answer some of these questions.
so thank you. We've had a question around vaccine effectiveness, and that was very well covered in the session, but I thought it would perhaps be worth just going over that again. So the question was, what are the statistics on vaccine effectiveness in prevention of shingles for Zostavax versus shingles? And I think that regarding the different endpoints, whether it's shingles itself or PHN or the other effects. I understand it was covered in the session, but would you be able to just go through that again, please, Robert?
Yeah, well, Zostavax we've had for 5 years. I've had it myself, and I paid for it on the private market. And it's moderately effective. It's good for post-herpetic neuralgia. It's about 2/3 effective, and that's a good figure. But a great figure is over 90%, and that's what Shingrix achieves. And so it is dramatically better to have Shingrix. And it's surprising that you can get such a strong immune response in elderly people. And I think it's the adjuvanting system, ASO1B. It uses the means by which to tickle the immune system along so much better. And it's also used in other vaccines like papillomavirus vaccines for teenagers, like malaria vaccines used in Africa for young children. So these adjuvants are really very impressive, and they do add to the armamentarium, and they really do make a difference to the vaccine protection that we're getting from modern vaccines. And just to add to the COVID side of things, we're likely to soon have a protein-based vaccine from Novavax that uses Matrix M, another adjuvant that improves the immune response and gives strong responses, whatever your age.
So an evolving area. Question regarding patients who've already received Zostavax and now want Shingrix to sort of top up their protection. What are the views on that, Robert?
Well, as long as there's an adequate gap, it's likely that Zostavax will give you good protection for 3, 4, 5, 6 years. And so after 4 to 6 years, you would be looking to top up your protection based on the studies, immunogenicity and ongoing protection effectiveness. So people like myself who had a vaccine perhaps 4 years ago might seriously consider having a booster with the newly available vaccine, provided you can access it and pay for it. So that's something that I'm considering for myself. It's reasonable to also consider having a vaccine even if you've had Zoster. For the first 6 to 12 months after you've had wild virus Zoster, you have an improvement in your immunity. So from 6 or 12 months after wild virus, you could also consider getting a vaccination as a booster to your immunity to stop it happening a second time.
Yeah, thank you, Robert. So do you think boosters should be a routine for protection against shingles?
Well, we have to look at the epidemiology. I always say, consider the disease, what's impact, and who gets it, and who gets it again.
Yes.
And like chickenpox, varicella zoster, the primary infection, all the reactivation can reoccur in somewhere between 5 and 15% of people. So the risk is not high, but it's palpable, it's real.
Yeah.
So I think it's something to strongly consider. I'm not sure it's strongly recommended yet. So I'm not about to make claims or suggestions that are over the top.
Okay. And Robert, Shelley's asked, should she encourage her 90-year-old mother to be vaccinated against shingles?
Oh, Andrew, thanks for an easy question. Yes.
Right.
If only my mother was alive today, she'd be in her 90s. And you look, the older you are, the more likely you are to get shingles. And what's more, the more likely it is to cause post-herpetic neuralgia, that severe pain that can lead to such distress and discomfort that people get depression and some
Yes.
even feel suicidal. So it's really something for the older people, and I really like the idea that we engage with the medical needs of older people in a real and a protective way.
Yeah. And got a further question about the second dose of Shingrix. The recommended interval is 2 months to 6 months, and the question is 2 months better than 6 months? I mean, it's a topic of the moment about optimal dose intervals. So I just wonder if there are any thoughts on that, Robert.
I'm not aware of impressive data for a difference. I think the range is there because it's an effective range.
Sure. Yeah, yeah. And if Shelley's mother came in at the age of 90 to have her vaccine and she got Zostavax, and then she said, look, I really want to get the Shingrix as soon as I can, what's the minimum interval before she could have the Shingrix?
Oh, look, I wouldn't be pushing for re-immunisation if you've had Zostavax. It's a good vaccine. And, you know, I think that's a good thing. And look, in younger people in their 60s and 70s, the immunity wanes, as I said, after 3, 4, 5, 6 years. In someone 90, it could be sooner. But I would rely on a Zostavax vaccination in a 90-year-old for at least 3 or 4 years.
Yes, thank you. And I know you said that you're a clinician and not a health economist, but I'm going to have to appeal to your health economist skills, because the question here is, when will Shingrix be put onto the National Immunisation Programme and be funded?
Yeah, that's an interesting question. And obviously, I'm not the expert, but what I can say is this. We've just spent a huge amount of money and we continue to spend massive amounts on COVID vaccination, COVID prevention. So the money is there, but it's spent. I've been an advocate for vaccination for over 30 years. And as a pediatrician, I've concentrated on diseases of very young children, like meningitis. And whereas the UK has introduced a vaccine for meningococcal B meningitis and blood poisoning some 6, 7 years ago, we're still not doing so because the PBAC, the Pharmaceutical Benefits Advisory Committee, says they don't see cost effectiveness. And that's really the key issue. Is there a strong argument for saying this is cost effective? And it's how you measure it. And we need to value we need to better value the benefits of vaccination, be they physical, hospitalization, GP visit, and also social. And about look at the value of the prevention of the disabilities. So all I can do is be the advocate that I am, and unsuccessful as I am for meningococcal disease in children. I'd like to see improved application of vaccination for the elderly. I think it would be great, but it's not up to me.
Good. Well, we'll see what happens. Watch this space. Yeah. So, got a question from Elizabeth, who's wondering if a patient thinks that they haven't had chickenpox previously, is the either Zostavax or Shingrix indicated or recommended?
Yeah, that's a lovely question. I didn't cover that very well. It's actually likely that by the age of 30, you've actually had chickenpox, irrespective of whether you think you have. So if you ask a pregnant woman whether she knows she's had chickenpox, or any adult person, they won't always remember, or they don't remember because they had it so mildly. You can have chickenpox as a child really quite mildly, to the extent that you don't even realize it. Of course, we all see in our clinical practice the severe cases with itch and fever and secondary bacterial infection and the like. But there is a significant minority of people who have chickenpox so mildly they don't know it and they don't remember it. But if you do a serological survey of people in their 20s, almost everyone has evidence of having had chickenpox.
Mm. We're probably a bit early in the day, but what happens when the varicella vaccinated cohorts start coming through? What are we going to do then?
Andrew, that's another important question. And I've been looking at that question actually for 25 years. And I remember reading the papers back in the 90s. The first studies of vaccinating children against chickenpox were done in leukemia patients in Japan and the US. And they followed them up for years. And they showed that they had a much lower rate of getting shingles after they were vaccinated than after wild virus infection. So the vaccination of children leads to a much lower risk of shingles later. But the UK for decades took the approach which said, if we don't have natural boosting in the community, and let me digress for just a moment, as a GP or as a nurse or a primary school teacher, you get natural boosting from exposure to patients or children with chickenpox. And that especially helps your T cells. That T cell memory is critical for your ongoing protection and prevention of Zoster. So that's my plug for GPs actually seeing their patients and not just talking to them over the phone.
Yes. Thank you.
So, so what the UK has said is if you give vaccination to children and you don't then get natural boosting in adulthood, you may hurry on the onset of Zoster. And the mathematical modelers took sway. And we all know they're not to be trusted.
Yeah.
We all know that modelers are only doing their best, but they're not about exact truth. They're about trying to get at the truth. And the UK took the approach to delay vaccination of children, but most other European and first world countries have said, yeah, let's vaccinate children.
Yeah. Oh, thank you, Robert. I've got two questions which are sort of age related, and I'll try and sort of link them together. So there's a question asking about risk factors for immunocompetent individuals other than age. What are the risk factors for getting shingles so that we might target these individuals for vaccination?
Well, age is absolutely critical, and the licensure of the products is from 50 years of age. And I had my first in my mid-50s. I'm now 60. I'm an old dude. Age is absolutely the best and the simplest. And we all know the people who are at risk of flu, who have a major medical problem, a chronic physical issue of the heart, the lungs, the liver, the kidneys. That doesn't apply below the age of 50. Yeah. Even though you might be immunosuppressed below 50, we don't advocate Zoster immunization below 50. So age is the critical cutoff.
And I think the other question which relates to that is you commented that there was the increased incidence of stroke and myocardial infarction following shingles. And the question is that an age-related phenomenon? Are we just looking at it because it's age, or is that actually an additional effect?
No, well, it's both. Yeah. There's no doubt that the risk of stroke in that first 6 months after Zoster is increased, especially in the first month, but it goes out to 6 months, and the risk of myocardial infarction is also increased in the weeks and few months after Zoster. So there's a cardiovascular effect of the viral infection, which is not good for you. And of course, those things are going to be more common the older you get. I'm willing to admit I've had a couple of small strokes myself, and I've been aided by other medical specialists who've diagnosed why I get them, and I'm on all the treatment that GPs give to prevent me getting another one.
Yeah. Thank you, Robert. I've got another question. I keep coming back to money, but this is related to, again, to the Shingrix. And the question relates to a patient who comes in for their first dose, but then says they can't afford their second dose. So what's the effectiveness after just one dose of Shingrix? What does that look like?
Yeah, thanks, Andrew. It's moderately good, but you get that second dose because you get definitely higher, longer, stronger immunity. So it really is beneficial to the patient to get that second dose, and to send them a reminder and send them another reminder. And hopefully it'll be on the national schedule before too long, and you won't have to require them to take a script and pay for it. My hope would be that just as Zostavax has been on the schedule, Shingrix will be before too long included too.
And Arlene's wondering, how long has Shingrix been used for? I mean, it's new to us here in Australia, but what's its track record overseas, Robert?
Yeah, well, an Australian actually has been critical to the development and to the design and conduct of the studies, Professor Tony Cunningham in Sydney. And the work has been going on for over 10 years. And the experience clinically is of 4 or 5 years in routine practice. We don't always get things straight away in Australia the way that a system like the US does. So there's really good experience to support not only the safety in large numbers and real world experience, but also the effectiveness.
Yeah. So my other theme for tonight, I've said, was one was money. The other seems to be age, and it comes back to: do you recommend the Shingrix or Zostavax vaccine for the under 50s? I mean, we seem to have a country, no.
Yeah, no, it's not indicated. The risk epidemiologically, and I'm a bit obsessed with risk stratified by age, by sex, by socioeconomic status, by ethnicity, by whatever. I'm always interested in why are you particularly at risk, and if you're under 50, you're not particularly at risk, and so it's not recommended.
Indeed, yeah. Look, I'm just
I said in the presentation, as a medical student 40 years ago, when I was 20, I had it, and I was doing a GP term at the time, and had a marvelous GP that I was being mentored by, and he helped me to recognize that my thoracic lesions were so mild. Young people get zoster so mildly. GPs see children all the time, and just to go to the epidemiology, if you have chickenpox under a year of age, number one, you can get it much more severely, and number two, you're much more likely to get zoster even as early as teenage years. So that's just a throwaway.
Sure. I've got another question, which was serology. Is there any value in checking serology before giving the zoster vaccines?
No.
No, thank you. I suspected that was the answer, but I thought
serology is expensive. It's not always accurate. And given that everyone's had chickenpox and has antibodies by 30, no.
Sure. Yeah. And another question, talking about time, if a patient has had shingles, how long after the shingles must one wait before giving either Zostavax or Shingrix?
Yeah, I'd personally, I'd wait a year. You've got tremendous T cell immunity boosting from having the wild virus reactivation. It really does tease up your immune system.
Sure.
And so a year is a good time to wait.
Yeah, that sounds good. We're just about running out of time, but are we okay to do a couple more questions, Robert? Are you? Yes, I say we've got a few more here. So is the efficacy, I suppose we should say effectiveness, in people over 80 from shingles vaccine considered to be less than in the younger adults, the 60s and the 70s?
Yes, the studies for both Zostavax and Shingrix have tended to focus on people in their 50s, 60s, and 70s. There is some data for people in their 80s, and certainly with Shingrix, there's very strong immunological protection of people in their 80s as well. For Zostavax, I'm less cognizant of the data, I have to admit. But certainly for Shingrix, which is the new and more effective product, there's real evidence of protection and benefit for people in their 80s.
And if we're going for a sort of a 2-dose approach, would you recommend Shingrix first, then Zostavax, or Zostavax first, then Shingrix?
Sounds like you're talking about COVID.
It does. Well, there we go. It's
goodness. No, look, everyone has, a large proportion of Australians have had Zostavax in their 50s, 60s, and 70s, early 80s. We just published a paper a few months ago showing the real benefit of Zostavax for people in their 70s, and so it's been a good product, and it's still being provided, and it's still free on the National Immunisation Program. So Zostavax on its own is available. It's good. It's protective. It's safe. For people who've had it, say 5 years ago, they might want to consider even stronger protection from Shingrix.
And look, I will make this the final question because we're nearing 7 o'clock, and it actually brings in another virus, so not varicella zoster, and this is herpes simplex. And the question is Shingrix likely to have any cross protection for patients with recurrent herpes simplex?
Simple answer, no.
No.
But the herpes viruses, let me wax lyrical again, are just fascinating. There's a whole bunch of them that affect children to begin with. And herpes simplex has very similar clinical presentations, and all sorts of neurological complications can occur, such as facial palsies, Bell's palsies, and other issues with herpes simplex, affecting the 8th nerve as well with a Ramsay-Hunt syndrome. Look, herpes simplex, if only we had a vaccine, would be worth preventing. I'll leave it at that.
Thank you very much, Robert. Thank you for your time and interest in this education. If you have any further questions, please feel free to get in contact with the Immunisation Coalition via the details on the screen now.